Hello, I'm Sheryl McCarthy of the City University of New York. Welcome to One to One. Each week we address issues of timely and timeless concern with newsmakers and the journalists who report on them, with artists, writers, scientists, educators, social scientists, and government leaders. We meet each one to one. The statistics say we're living longer, but don't tell us how well we're living. Some of us live with extraordinary vigor, but the inevitable wear and tear of life takes its toll. We lose some of the essentials that allow us to successfully manage our lives. And when you add illness to the pileup, life can be overwhelming. The Memorial Sloan Kettering Cancer Center has become a pioneer for older cancer patients with additional needs. It's opened a geriatric service in the Department of Medicine, and heading the unit is Dr. Beatriz Korc, who is uniquely qualified to lead the service that tries to do more than just mend the body. Welcome.
Thank you.
I think we've all heard of, we've seen those advertisements on televisions for St. Jude's Children's Hospital. So we know children get cancer. We know people get cancer in their 20s, 30s, 40s, 50s. But I suspect a lot of people don't know that cancer is primarily or largely a disease of the elderly.
Yes, we are not only living longer, but there is also an increase in the amount of cancer, and the biggest increase is in the older population over 65. It is a disease. I would say most of the cancers are 65 and over, even though there is also, of course, cancer in the younger population as well.
Yeah. A doctor once told me that if you live long enough and some other disease doesn't get you, then cancer will probably get you eventually. And obviously there's some truth to that.
Yes, there is some truth to that. However, it is in the literature, though, if you are centenarial, if you are over 90 and you haven't had cancer, your possibilities go down.
Oh, well, that's great. Yep. I'm going to aim for that then. How long has the geriatric service at Sloan Kettering been around, and why a separate service for older people, for older patients?
The group that is called the 65 plus team has been around now for probably 4 or 5 years, and it's an interdisciplinary group that is consistent of all the disciplines. It has people interested in the geriatric population from physical therapy, occupational therapy, social work, pharmacy, nursing, research. However, the medical piece has been around only over the last 6 months that we created a service, a geriatric service within the Department of Medicine.
And what does it do? Does it attend to all the other kinds of medical issues that older cancer patients have?
Well, it has outpatient and inpatient services. It takes care of patients that are referred to them from the oncologists.
Okay.
And usually are frail, older patients that have other medical problems that are in addition to their cancer.
I see.
Or they have multiple medical problems or multiple medications or what we call geriatric syndromes that are specific from the elderly.
My grandmother died at 75. My father died at 85, and my mother is approaching 90, which suggests that my generation is going to be we're going to live a long time, well into our 90s, possibly into our hundreds. So it sounds like there's going to be a lot more work for, both oncologists who are treating patients, and for people in services like yours as the population gets really, really old and starts to come down with cancer.
Right. There is going to be a lot more work, and probably there is going to be more work in that area than there's going to be geriatricians to do it. So one of the most important roles is not only to take care of these patients, but to educate other physicians, primary care physicians, family medicine, or the oncologists to take care of the geriatric problems.
Do geriatric patients, or do geriatric people, do they get different kinds of cancer than younger people? Or do they respond to cancer in a different way?
They do. There are some cancers that are more frequent in the elderly. The most frequent cancers in older people for men is prostate cancer. For women, the most common cancer for older women is breast cancer. They not only that they respond differently, but because many of them have a lot of other medical conditions. Many of these people are frail. Many of them have a lot of medications that are in addition to their chemotherapy or whatever treatment they're getting for cancer. It's the combination of all this that put them at risk of complications.
Mm-hmm. Tell me about some of the components of the geriatric service at Sloan Kettering, you know, some of the services that you offer.
It's an evolving situation right now because we are very young. But at this time, we're doing several different activities. So we have referrals to the outpatient clinic, and we have clinics every day, and we see two kinds of patients. We see patients that are going to have surgery, so these are called preoperative evaluations we take care of patients that are over 75, and we do these evaluations prior to their surgeries. And we see patients that are referred from their physicians, because just to see the whole picture, follow them up together with the oncologist, sometimes follow them up as they get admitted as well. Even though our ultimate goal is just to work with the oncologist to see which of these patients are going to do better and which patients are going to have more complications during their cancer treatment.
You also have various, I was looking at your website, you also have various groups,
Yes.
I guess support groups. Tell me about some of those.
We have nursing that is very supportive, not only for education of nursing, but nursing also taking care of the patients. Physical therapy and occupational therapy, they mostly are involved in the care of the elderly as an inpatient. We have a geriatric pharmacist that would come and evaluate with the patients their medication list and try to make it simpler or take away medications that are not appropriate for an older patient. Social work is very active, and they have several activities that are related to the geriatric patients, as well as psychiatry as well.
And you also have support groups that the patients belong to, and I guess their caregivers belong to or spouses belong to, correct? Is that something?
We are developing those.
Okay.
They are not 100%, even though at this point we have support from the social work department to caregivers and to the patients, and also from psychiatry. There are groups that they do with the older population, and they're very, very well attended, and they can come and go as they please. They don't have to commit to it, so they like it very much.
Is there a part of the program that you think has been particularly successful, or that you think is particularly important in terms of what it does for these patients?
I think it gives them the patients a sense that everything else is also being looked at. Is comforting. Sometimes patient satisfaction goes higher, and that is important, as well as family members that are involved with us in the care of these patients. It's very especially satisfying if we are able to intervene as they are in the hospital and prevent things that many times happens with older patients just because they are in the hospital.
For example?
Well, hospitals in general for older patients are not a good place to be. So there are risks of many things that happen. For example, patients getting out of bed and having a fall, or being in bed for a long time and developing a pressure ulcer, or patients that get confused just because they are in a strange environment and because of all the medications they are having. So all those and there are many of those. They are called, as a whole, they are called hazards of hospitalization. And I think early intervention can prevent lots of these complications.
Now, you are a gerontologist. Now, as my generation ages, and there are a lot of us, and we're aging rapidly, there's going to be a need for more doctors like yourself. But are more doctors going into that field? Are they creating more fellowships for gerontologists? Is that happening?
Not really. I think that I don't know if less are going to the field, but there's certainly not more. So that's why I don't think, and that is a well-known statistics, that there will never be enough gerontologists or geriatric physicians that are able to take care of all the adults that are coming into the older adult age, like all the baby boomers that are going to retire in the next 10, 15 years. So that's why our main role is not only taking care of patients, but education of other physicians about this.
Now, Sloan Kettering has a reputation of being on the cutting edge of cancer treatment and research. Is that treatment available, but it's located on the Upper East Side, is that treatment available to everyone? I mean, regardless of their income, or does one have to be well off or to have a really great medical insurance to be treated there? How does that work?
Oh, no, everybody can get treated there.
Really?
Every person that gets in the hospital can have their care and our care. Patients with insurance, patients with Medicare, with Medicaid, with private insurance, private paid, international patients, anybody can get it. Yeah.
They just have to be referred by their doctor, or how do you get into Sloan Kettering?
Oh, there are many ways to get in. One is you go to a primary care physician, you have a cancer, the primary care physician tells you, gives you a referral, tells you this is a good place to go. Some patients have an oncologist in other places and they want a second opinion, so they just make a phone call and they go. They can access the website and they have the information how to get a physician from there.
Okay. We're going to take a short break, but we'll be back after the following messages.
Say, are you worried about H1N1? You know, swine flu. Well, CUNY says protect yourself from hidden horrors. Here's how. After touching public surfaces, don't touch your eyes, nose, or mouth. Flu is also spread when infected people cough at you. Sneeze into a tissue, never your bare hands, or use your elbow. Wash often with soap and water, or use an alcohol-based hand cleanser. There are two kinds of flu shots this season. Consult your doctor or healthcare provider on the regular and H1N1 vaccinations. Most importantly, if you feel sick and have fever, stay home. Yes, a little caution goes a long way.
For more information, visit our website, cuny.edu, and click on H1N1 Update.
Welcome back to One to One. I'm Sheryl McCarthy of the City University of New York, and I'm talking with Dr. Beatriz Korc, Chief of the Geriatric Service at Memorial Sloan Kettering Cancer Center. One of the reasons, I think the reason that people dread a cancer diagnosis so much is, one, they fear it might be a death sentence, but two, they also fear that their treatment, they're going to have to go through this really miserable and painful and debilitating kind of treatment, and then in the end they probably or may die anyway. One of my previous guests on this show, Julie Salomon, wrote a book about Maimonides Hospital in Brooklyn, and she talks about how cancer treatment with the surgeries and the drugs, the radiation, the x-rays is a very lucrative business for hospital and doctors, and her book suggests that one of the reasons the medical profession puts patients through such aggressive treatments, I mean, one is for research purposes and another is it's lucrative. In fact, one of the doctors in the book, this was a cancer doctor, was talking cynically about putting patients through this really aggressive and difficult treatment and saying, and how many people do we actually cure anyway? We don't really cure anybody. Do you think that we overtreat cancer patients in this society?
Well, that's a very big question. Sometimes, probably we do. But what I've seen, to tell you the truth, I'm not an oncologist, so I've been working in this institution only for the last 6 months, is that there is a profound care for the patient. And patients come with a lot of hope. And they really want to get the best they can be treated and trying to get as much survival as they can. So there is a quota of overtreatment, but I think that overall patients are treated to give them the best options they have. One of our roles in geriatrics, actually in Memorial, is to try to screen from the get-go which patients are at risk from having a lot of complications from aggressive treatment. And in that way, try to work with the oncologist to see if there's anything that has to be adapted or adjusted to their other medications or to their other problems. Try to avoid to get them worse than they were before they started.
Right, right. And to sometimes say, well, maybe you don't want to pursue that aggressive treatment with this person?
Probably that is a conversation that it has to happen among all the parties, right? With the patients, with the family, with the oncologist, with the other physicians, to get to a consensus on what is good for the patient. Because sometimes you put them through certain treatments that will cure their cancer or improve their cancer, but at the end of the line, their quality of life is going to be so low that it's not going to be acceptable for the patient.
Right, right.
So that is probably one of the most important goals of all this new department that it's growing this time.
Now, we read about breakthroughs in cancer research every day, but have survival rates really improved, and what kinds of survival rates are we talking about?
Survival rates have improved significantly. And if you look at the graphs of how many survivors there are in this country, it has grown tremendously to the millions. So to the point that there is a whole new group of physicians that need to take care of these survivors, and sometimes there's not enough knowledge of what to do with the complications of the medications or of the treatment that they had many years prior, and now there is a whole new group of patients that are surviving 10, 20, 100, 50, 40 years.
What do you consider the most significant advance in the medical system's response to cancer that you've seen over the years? Is there something that stands out for you?
Not really. I think having there is a whole range of treatments that are out there, from surgery to all kinds of treatment relative to radiation therapy. Chemotherapy has improved significantly. There is a lot more treatments that are not so aggressive as they had been before. There is hormonal treatments and immunotherapy. So there is a whole bunch of different ways of treating cancer right now.
Does one's age have an effect on one's chances of surviving cancer? I mean, I know, for instance, if you look at men who develop prostate cancer when they're in their 70s or 80s, quite possibly have a better chance of surviving that because the cancer grows more slowly, is my understanding.
Yeah. Well, it depends on the cancer.
Yeah.
The one that you pick, prostate cancer, grows slowly when you're older. The possibilities of surviving is better. But there are other ones that are aggressive, so you need to have aggressive treatment. So the possibility of surviving as you grow older, because of you're frail, or because you have all other medical conditions, so the possibility to survive goes low.
Right. Now, in your particular service, how involved are you in your patients and in your patients' families' decisions about whether or not to continue treatment or to stop treatment? Is that something that you get involved in with them?
Not right now. This is a discussion between the families and the oncologists.
Okay.
What we do is that we give recommendations in what we think the patient is able to tolerate, or what is things that they need to look for or improve or adjust. But right now we do not participate in the decision-making process.
Is hospice care a part of your service at Sloan Kettering?
It's not part of my service.
Okay.
There is a palliative care service, pain and palliative care service in Sloan Kettering that is a different service than ours. And but this is not hospice. Palliative care service is palliation. Hospice is a different thing altogether.
I see. Palliative care has to do with dealing with pain and discomfort, or?
Palliative care exactly needs to pain, discomfort, taking care of symptoms. So make your symptoms better. Hospice is end-of-life care, when you know that you have six or less months to survive.
Right, right. My understanding is, and I learned this from my show producer, is that we all have cancer cells in our bodies, which require triggers in order to develop into actual cancer. Is that correct? And if so, what are some of the triggers?
There's a lot of theories about this, because people get more cancer because they're older, because they have more time for those cells to develop. None of those are 100% well known. What are the triggers? Sometimes it's your immune system going low is one of the theories, and then you're developing, the cancer cells have more strength to grow and develop into a cancer. But I cannot tell you right now that this is a 100% well-known thing.
Yeah. We hear all the time that the best way to avoid cancer is to eat fresh fruits and vegetables, avoid a lot of red meat, exercise, keep your weight down, don't smoke, have annual medical checkups. Is that still the best advice, or would you add anything to that list?
I think that's the best advice. There are many cancers that you can do screening for, and then therefore, if you are going to develop it, you are going to detect it very early. It's good to have your mammograms in a yearly or bi-yearly basis, to have your colonoscopies, and starting from the age of 50, women that have pap smears to prevent or to detect early cervical cancer. So there are ways that you can try to, if not preventing, at least detect it early.
What drew you to this area of medicine?
To geriatrics. I think it was an evolving thing for me. I really enjoy taking care of the older patients. I think that many of our older Americans are living longer, they're living well, and it's very rewarding to be able to keep them going in a very good quality of life and having the less complications as possible.
I touched on this before, but do you have a sense that there are, I mean, since we have all this aging population, do you have a sense that more medical school graduates are going into geriatric medicine or not?
No, I don't think they are. Our medical groups are, physicians are very specialty oriented. We are having a little bit of a loss, not only in the geriatric medicine, but in the primary care physicians altogether.
Yeah.
So
just because the specialties pay so much more.
Specialties pay more. They have, in some of the cases, a better quality of life for the physician. So there has to be a change, probably, in the way that medicine is looked at, and the amount of primary care physicians that are going into primary care and into geriatrics.
Now, did I hear you say earlier that breast cancer is the most common form of cancer among older women?
Yes.
Really? Okay.
Yes. Breast cancer, colon cancer are one of the most common cancers for women, too, and prostate and colon cancer for men.
Now, there have been in the news recently findings about, I'm sorry?
And lung cancer in both of them.
Okay. There have been findings about problems with early diagnosis, whether it is some of the tests, whether it's mammograms, whether you get having these mammograms, and you have women going through all of these tests and whatever that they don't need, giving you sort of false indicators. And I think also that's been true. There's been some issue about it regarding diagnosing the test for prostate cancer. Any thoughts about that?
Yes, well, all the screening tools have some possibilities of having false positives. You try to the ones that are approved and they are recommended for all the task forces are the ones that you have the more possibilities of doing good than bad. So, for example, in mammograms, the recommendation of doing a mammogram every other year, the possibility, it has reduced significantly the amount of breast cancer, or has improved the breast cancer that is diagnosed early.
Right.
In the case of the prostate cancer of the PSA, there is a possibility of having false positives. It's not a strong recommendation to have it checked, and it's a conversation between the patient and his physician of the pros and cons of being checked in a routine way.
What's the most rewarding part of your work?
Seeing a patient that is doing well, that is recovering, that is able to go on with their lives, that is going out of the cancer treatment with a quality of life that is similar to the one they had before they were diagnosed, and that they are not, and that all this treatment is not a trigger for a decline that would take them into a different place. Right.
Yeah. Well, I'm sure your work is not only rewarding but challenging and certainly very important work to do. And certainly kind of work that there's going to be a need for more and more people like yourself to do as people like me get older and older and more decrepit. I want to thank Dr. Beatriz Korc of the Memorial Sloan Kettering Cancer Center for joining us today. If you'd like more information, check the website at mskcc.org. And for the City University of New York and 1-to-1, I'm Sheryl McCarthy.